Thank you very much. It's a great pleasure to be here, and I'd like to just begin by thanking so many of you for the support you provide to Paul Young and his research based in Wellington, and also mention how grateful I am the way I've been welcomed into the ICU community. Now, what I'd like to do is just look at some of the dogma we have in terms of oxygen therapy, and I'm going to approach this as an internal medicine physician. And the data I'm going to show you is not based in ICU, because you're familiar with the ICU data. So what I want to do this morning is really just give you a bit of an oversight of an internal medicine view of oxygen therapy, and really challenge one by one the different dogma by which internal medicine has practiced in terms of the delivery of oxygen over recent decades. And I'd like to begin by starting with the heart, and I want to just briefly mention the effects of oxygen beyond the lungs. And this is a recent study undertaken from the States, where they put a wee ultrasound probe down into the coronary arteries and measured flow, both in normal, in the open squares, circles, and coronary in terms of the closed circles. And what you can see is that oxygen reduces coronary blood flow by about 20%. And the reduction in coronary blood flow is more marked in normal subjects, but also occurs in those with coronary artery disease. So oxygen has effects beyond the lungs, and one might ask, well, what are the significance of these and other effects in terms of the cardiac effects? The first randomized controlled trial was undertaken in 1976, published in the British Medical Journal. So all the cardiologists in the Western world would have read it. And it showed that if you give high-flow oxygen for 24 hours compared to room air, that you got greater release of AST, indicating a bigger myocardial infarction. And although the study was not powered to look at mortality, there were only 200 subjects in the study, that those who received high-flow oxygen had about a threefold higher mortality rate, not significant, than those with room air, suggesting that perhaps the reduction in coronary blood flow in the setting of a myocardial infarction, or perhaps the greater reperfusion injury following the myocardial insult, may have resulted both in a greater size of the infarct and a greater risk of mortality. And I mention the year this is done because I think it's significant that the next study in this field was not done for over 30 years, indicating that as clinicians we have a blind spot in terms of therapies that we administer that potentially cause harm where we don't want to know about it. And it's extraordinary when you think of the huge studies in cardiovascular disease, in particular myocardial infarction, that there was not a study repeated for over 30 years. In fact, we attempted one sub-study and undertook that with Anil Ranchod, who was a cardiology registrar training with us. We did a very similar study, powered around the 150 mark. We looked at MRI scanning to look at infarct size. And in fact, we were unable to determine a difference between the two groups in terms of titrated versus high-flow oxygen therapy. And together with a Russian study, we put the three studies together and found that the current evidence base is that high-flow oxygen, compared with either room air or titrated oxygen, increases the risk of mortality by about twofold, but a non-significant difference. So this issue is unresolved, and is it a concern that it is only until very recently that the cardiology guidelines have recommended a more cautious titrated approach to oxygen therapy in myocardial infarction. I think, sort of alluding to one of the earlier questions from the previous speaker, I think also we have a tendency to really go high-tech in terms of our new approach to diseases, but I think there's room to still look at the common management approaches that we take, many of which are not evidence-based. The biggest gains may be in the standard management approaches than necessarily some high-tech advances. Now, in internal medicine, a significant proportion of our workload is patients with severe exacerbations of COPD. And it's interesting that over 50 years there's been repeated demonstration of harm in studies of high flow versus titrated or room air in terms of particularly the effects of CO2, and also in terms of patient outcomes. But it was only until very recently that we had the first proper randomized controlled trial undertaken by a group in Tasmania. And what they did is they looked at high flow oxygen, which was 6 litres per minute, plus nebulizer driven by an oxygen-driven nebulizer, versus titrated oxygen, 88 to 92% is the target, plus air-driven nebulizers to deliver bronchodilator. So there's 2 components to the titrated conservative oxygen therapy regime. And this was run in an ambulance service, and this was the immediate treatment, and then the outcome was what happened once they reached hospital. And what they found, if they looked at the high flow oxygen versus the titrated, and all patients were picked up with an exacerbation of COPD, that titrated oxygen resulted in a 0.4-fold relative risk of mortality compared to high flow oxygen. And if they looked at the subgroup who they definitely had confirmed COPD, there was about an 80% reduction in risk of mortality. So if you look at a 9% overall mortality rate compared with a 2 to 4% depending on the criteria used, you can see that the single most important determinant of outcome in terms of COPD exacerbations is the oxygen that are administered in the first 45 minutes of their care. And I say first 45 minutes because that was the average duration of therapy that was given prior to attendance in hospital. If we look at the physiology and those who got blood gases within 30 minutes of attendance in ED, we see that within such a short period of time, dramatic difference in terms of physiology, in terms of both acidosis and also in terms of the increase in PCO2. So we now have, for the first time, level 1 scientific evidence of an increased risk of mortality with a high concentration oxygen therapy, and I think that can now be considered as misadventure in terms of the care of such patients, and that the titrated regime of 88 to 92% is where the evidence base currently lies. Now, we don't actually know whether 88 to 92% is the preferred range, and what we now need is studies that perhaps compare that with a range of 92 to 96% or somewhere in between to try to see where we get the right balance in terms of the risk of hypoxemia and the risks of hyperoxia in these patients who often have significant comorbidity, in particular cardiovascular disease. Now, of course, we're interested in the effects of oxygen on COPD because many of the physiological abnormalities in terms of VQ mismatch and airflow obstruction in COPD are also observed in patients with asthma. And until very recently, the recommendations for patients presenting with a severe exacerbation of asthma is to give high-flow oxygen therapy to avoid potential hypoxemia. So Carl Perrin and our group did a randomized controlled trial of high concentration versus titrated oxygen therapy in severe exacerbations of asthma, and this was the first trial of its kind. And it was giving patients either 8 litres per minute for 60 minutes, high-flow oxygen, or titrated oxygen between 93 and 96% in the controlled oxygen treatment regime. And what we find here, so this is the high concentration versus the titrated oxygen, range 93 to 96%. Treatment for 60 minutes in patients presenting to the emergency department with severe asthma. We call this change of 4 or more as a physiological effect and a change of 8 or more as a clinically significant effect. Somewhat arbitrary, but to divide those two range between physiology and a clinically significant effect. And we found the risk of a patient having a physiological increase in PCO2 was 2-fold greater if they got high concentration oxygen therapy, and of a clinically significant increase in PTCO2 was associated with a 4-fold relative risk. Now, I don't think we should be surprised by these findings because, as I mentioned, many of the physiological abnormalities you get in COPD are similar to what you get with asthma. So, in fact, we're seeing a similar effect in terms of CO2. Now, of course, this level here was somewhat arbitrary, so we really wanted to get another perspective in terms of the clinical significance that 60 minutes of oxygen therapy administered in this way may result in. And so we looked at those patients who at 60 minutes had a final PTCO2 of 45 millimeters or more. And in fact, all 10 patients who had acute respiratory failure had received high concentration oxygen therapy, and in 5 of those, they'd had an increase in their PT-CO2 of more than 10 millimeters. So in fact, if you look at this level of increase in CO2, we can either look at it as a risk marker of severity, or we can also look at it as a determinant of a poor outcome. No matter which way we look at it, you could also argue then that the administration of high concentration oxygen therapy in this population at least may be the determinant of whether patients get into this high-risk group of acute respiratory failure. So we moved on from that and did a similar study with an almost identical design where we looked at patients who were attending the Wellington Emergency Department with suspected community-acquired pneumonia. We did the same design in terms of 60 minutes of either high concentration, 8 litres per minute, or titrated, 93 to 96% in terms of their oxygen therapy. And I should have mentioned that many patients, of course, required no oxygen therapy at all. Most patients who present with either severe asthma or community-acquired pneumonia who require hospital admission, the majority of them do not need any oxygen therapy in terms of keeping the oxygen saturation at least above 92%. When we look at these physiological and clinical changes in carbon dioxide, we see that those who got high concentration oxygen therapy had an increased risk of between 3 and 6-fold. So that was a model very much of VQ mismatch in terms of community-acquired pneumonia, and there's very good mechanisms why you might suspect that with oxygen therapy you get release of the hypoxic vasoconstriction, pulmonary vasoconstriction, and that would lead to worsening VQ mismatch and increase in your physiological dead space, which would result in an increase in your CO2. So we had good reasons why we might expect an increased CO2 in both asthma and in pneumonia, in addition to COPD. So we then moved to the other proposed mechanism in COPD, which may relate, that may cause an increase in CO2 in terms of a change of your respiratory drive. So we looked at the model here of patients with hypercapnia and patients with obesity-associated hypoventilation. And all these patients had a PCO2 of greater than 45 as their resting baseline, and they all had morbid obesity with BMIs of above 40. This study we were actually able to control more tightly than our acute presentation study, so we got them on 2 different days, and we gave them room air and a big Hudson bag on one day, and we gave them 100% oxygen for 20 minutes on the other day. 24 subjects, and 3 of the 24 subjects we had to abort the study within 20 minutes because they had an increase in CO2 of more than 10 millimeters of mercury. That was a safety criteria that we had in the study. And I happened to be present in this subject here. Where the person came in, we linked them up, put them on, and then potentially over that 10 increased by 1 millimeter per minute. And once we got to this stage here, in fact, he overshot beyond 10 by the time we got the mask off him, he basically went to sleep. He became semi-comatose. He woke up quite quickly to stimulation, and he suffered no consequences. But you can imagine an obese patient with comorbidity who goes to ED, perhaps hypoxic on a pulse oximeter when they first present, perhaps low acuity, sent off into a side room, given a high-flow mask because his sats were a bit low, and then gradually going into progressively worse acute on chronic respiratory failure. Okay, so that's sort of the clinical interpretation of these findings that we had in terms of these subjects who responded most dramatically. But in terms of the overall group, this is just 20 minutes of 100% oxygen versus room air. The increase in CO2 went up on average by 5, and this was due to both a reduction in the minute ventilation and an increase in the physiological dead space. So what can we conclude by these series of studies, in particular based on the significant data in COPD, but the emerging data in terms of asthma, pneumonia, and obesity hyperventilation in patients who are in chronic respiratory failure? Well, I think we now have enough evidence that we can state that high concentration oxygen has the potential to increase the PaCO2 in a wide range of both acute and chronic conditions where there is either VQ mismatch or chronic respiratory failure. And so I think we have to move the concept of titration of oxygen therapy from COPD with an established range of 88 to 92% to other acute and chronic respiratory, and I could probably include cardiovascular conditions, where we perhaps would aim for a higher titrated oxygen range. And certainly on the basis of our studies, we can look at values somewhere between 92 and 96% as being a reasonable baseline. Right, so it's interesting if you go back to the Australian study, the RCT and COPD, they were really helpful in terms of reporting the protocol violations in their study. They trained up their team really well. They had a comprehensive training program, yet half of all patients in the titrated group had high concentration oxygen therapy at some time in their pre-hospital treatment. The ambulance service could not stop themselves on half the patients in giving them high flow, even though they knew they were in a clinical trial and that was something that they were not allowed to do. There is such an entrenched culture within the medical and paramedical community that we need to consider how we change the hearts as well as the minds of those who administer oxygen therapy. And it's interesting that there are still audits being done following this study showing that in Western communities where you would think evidence-based medicine was the practice that we followed, where high concentration oxygen therapy is still routinely administered to patients with COPD. Some may need it, but only those who you need it to titrate to that saturation range of 88 to 92%. So I think we need, and this is really just a rerun of the BMJ story with the myocardial infarction in 1976, that we seem to have this problem that we feel we are obliged to give high concentration oxygen therapy, even if we know there may be some harm. So I'd like to explore this issue of the hearts and the minds and the entrenched culture a little bit further. Because I think we need to ask ourselves, why is it that the cardiologists will tolerate, or may not even notice, a 30% reduction in cardiac output? Many clinicians will tolerate a 30% reduction in hemoglobin concentration. You know, we're not going to transfuse someone whose hemoglobin is around 105. We might worry, the cardiologist might worry why the ejection fraction is down, and the internal medicine physician might worry about why the cause of the reduction of oxygen carriage capacity from a reduced hemoglobin, but it's not going to lead to any emergency treatment. Yet few clinicians will tolerate a 10% reduction in oxyhemoglobin concentration, perhaps except in those older patients who fly, where we don't seem to worry about it, or those with obstructive sleep apnea, where patients are often desaturating down to 70% routinely overnight, a huge burden out in the community that we don't conveniently worry about. So we must ask ourselves, why is this disparity between the lack of concern in terms of oxygen delivery to the tissues in these scenarios and this scenario, but we don't worry about obstructive sleep apnea? I think the problem is that we're confusing risk with magnitude. The problem with an oxygen saturation of 85 to 90% is not that there's a life-threatening reduction in oxygen carriage. We know that because every older person who flies and walks to the bathroom on a plane will have an oxygen saturation, if they're lucky, between 95 and 90%. What is the concern is that the condition that has caused that reduction in oxygen saturation may well be life-threatening. And I think we've been very poor in understanding this concept, that the reduced oxygen saturation is a marker of severe disease, but in itself does not represent a life-threatening reduction in oxygen delivery to the tissues. And I think perhaps some of the problem lies in the way we view the oxygen hemoglobin dissociation curve. Now, this was the curve that I got taught at medical school, and I don't remember much from my medical school days, but I do remember we had this thing called the slippery slope, that we had to make sure that we kept patients away from that slippery slope that led to death. Okay? And I'm sure many of you in the audience were taught that as well in terms of the oxygen dissociation curve. Well, in fact, I think that is the wrong way to look at this relationship, which has evolved in an evolutionary sense over millions of years, to be an incredibly efficient way to pick up oxygen and deliver it to the tissues. So in fact, what the slippery slope is, that is really the point between this very flat bit and this very steep bit. And what this very flat bit, it is the ability to almost fully saturate the hemoglobin despite marked reductions in oxygen tension. So the curve has evolved to allow the almost complete pickup of oxygen onto the hemoglobin despite marked cardiovascular and respiratory disease. Now, of course, what drives oxygen into the tissues is the pressure gradient. So in fact, the steep part of the curve is the ability to maintain the pressure while you're dropping off the oxygen into the tissues. So I think we should view the slippery slope differently, that it really is the point of inflection between the very great ability of the hemoglobin to pick up oxygen and then to maintain the pressure, which is the gradient of pressure driving into the tissues, despite dropping off oxygen into the tissues. And so we've proposed in a commentary in the Lancet that it would be better if we actually reverse the axes, so that in fact we have a hemoglobin saturation on the x-axis and the oxygen tension on the y-axis. And naturally, there's no slippery slope that you can identify in a visual sense. But we can see just as well the ability to pick up and almost fully saturate the hemoglobin despite marked reductions in oxygen tension, and then the ability to maintain that oxygen tension despite dropping off oxygen to the tissues. And so I think it perhaps may be helpful for our medical students and junior doctors, and perhaps some of our colleagues, to just reflect on the different impact of viewing the dissociation curve in these different ways. Now, this next figure is actually a little bit complicated to explain, but what I want to show you is the modelling that addresses the issue of whether administering oxygen protects the patient in case they get worse. Because one of the arguments I hear from staff is that, why did you give this person oxygen? Well, they were a bit hypoxic and we were just worried that they might get worse, so we put on high flow oxygen to protect them. Okay? So this is a model of a person who has rapidly worsening intrapulmonary shunt, starting at 15% and worsening by 10% every 60 minutes. This is a person with a progressive PAPS pneumonia, well, that's slightly dramatic perhaps. Initial presentation, their oxygen saturations were 88%, and you have two options. One is to administer an FiO2 of 30%, and the other is to administer an FiO2 of 60%. We'll take this 30% first. They then get an oxygen saturation of perhaps 95% on the pulse oximeter, put onto the ward, and they deteriorate fairly dramatically. Okay? Their oxygen saturation, and here's the PaO2, will gradually reduce. And when the saturation falls to less than 90, the nurse who's monitoring the patient will pick that up as a saturation that's gone less than 90, and they will call for a review. The patient continues to get worse, but you've got the ability to increase the inspired oxygen, perhaps to 60%, and you've got this nice hour and this rapidly progressively deteriorating patient to actually perhaps arrange admission to an HDU or an ICU if required. If we have the same patient who gets put on high flow oxygen to protect them because the doctor attending had this very good sixth sense that the patient was getting worse, you will not pick up any change in physiology based on dropping PaO2 until the saturations fall to less than 90%. So there'll be no deterioration in terms of the pulse oximetry. It'll be around 100%, and it'll stay around 100% till here, and then it'll gradually drop down to less than 90%, at which stage there is limited ability to increase the oxygen delivery while the patient continues to deteriorate. There is delay in recognizing and then being able to seek medical help. And there's some good data in terms of perioperative care that this actually applies to clinical practice. That if you routinely give a person who's hypoxic high flow oxygen beyond the level of their physiological requirement, that you will lead to delay in determining or recognizing a deteriorating clinical situation. So I think there's now sufficient evidence to conclude that the routine use of high concentration oxygen in patients with hypoxemia delays the recognition of clinical deterioration. However, if we titrated their oxygen therapy to the mid-range of 90 to 100, that you can detect a deterioration earlier and have the ability to intervene before a life-threatening situation presents. So if we look at the current dogma in terms of oxygen therapy, let's see if we can pick these off one by one. The routine administration of oxygen in a breathless patient is useful, harmless, and clinically indicated. That's incorrect. It has potential adverse effects, not just relating to the lungs, but also to the heart, the brain, the other vital organs, and it may change behaviour in terms of not being able to recognise it in a deteriorating condition. Exposure to an FiO2 less than 60% is certainly not without adverse effects. They're both pulmonary and cardiovascular. There's very limited data. In fact, there's data to suggest that this statement is also incorrect, that keeping patients well above the slippery slope is a flawed and outdated concept. And this statement that a patient at risk of developing hypoxemia can be protected by administering high concentration oxygen therapy is also flawed. So I'd like to just now briefly mention the studies that Paul and I are undertaking in Wellington with the support of many of you in this room. The first is the CLOSE 1 study, which is a pilot feasibility study undertaken in New Zealand, Australia and France, where we're looking at 80 mechanically ventilated patients, looking at a conservative oxygen strategy versus a liberal strategy. And the purpose of the feasibility study are very simple. It's really to determine whether we can go on to a full-scale study. So we want to see whether we can effectively get separation in terms of oxygen saturation between the two randomised group, whether it's feasible in terms of rates of recruitment, and whether we can examine trends in the clinical outcomes, whether there's any signal at all. And that study is almost finished. The next study is the hot or not study, which has been undertaken initially in Wellington, and now it's expanding to additional ICUs throughout New Zealand. And that's looking at the issue of community cardiac arrest, where we're looking at standard 100% oxygen, followed by usual clinical practice, compared to titrated oxygen, 90 to 94%, with a self-inflating resuscitation bag. Now, we actually stopped the study after 18 patients had been randomised because it was clear that in a poorly perfused patient post-cardiac arrest, it was not possible to get reliable oximetry readings to actually determine that safely and get separation between the two groups. And so we're now redesigning the study to look at it as a ED-based study rather than an ambulance-based study where we randomise to these two treatments at the time of their presentation to the emergency department. So that were the objectives of the hot or not, and we've already determined that we cannot reliably use this design, and we need to go from community to a hospital-based study. We're still quite interested in exploring this issue in terms of what are the acute and chronic respiratory conditions and how do they respond to oxygen therapy in terms of the CO2. And so we're just completing studies in neuromuscular disease, pulmonary fibrosis, bronchiectasis, and also in obesity, excluding the obesity hypoventilation syndrome. And between here we have different models in terms of the physiological abnormalities that lead to hypoxemia in these patients. And we're hoping this will give us a better insight to what degree the findings in COPD, asthma, pneumonia, and obesity hypoventilation may apply to these other respiratory conditions. We also have some interest in the high-flow nasal cannula device, which is now widely used throughout New Zealand, not just in the intensive care unit. And we're intrigued by some of the physiological effects, in particular, evidence that it may reduce alveolar dead space. And there's some evidence for that. And so we are now, I've got two studies here to show you, and I think since the slide was presented, there are some more abstract presentations. But basically, high-flow nasal cannula reduces physiological dead space, improving alveolar ventilation in healthy subjects, and we would expect that would result with a reduction in CO2. And it's been shown in the study from Auckland that it reduces PaCO2 following cardiac surgery. So our primary interest, of course, is in COPD. So we're now doing a randomized crossover study to investigate the effects of titrated oxygen on CO2, where we look at low flow and high flow nasal cannula, titrated to the same level of oxygen saturation, and just see whether what effects they have comparatively in terms of PaCO2. So by concluding, I'd like to say that I think that we have seriously got it wrong in terms of oxygen therapy over the last 50 to 100 years. We've been very slow to recognise harm that has been shown in clinical trials, and we've been very slow to change practice on the basis of evidence. And I think that we are now in a period where titrated oxygen therapy should become the norm, and the priority is to determine what levels of titration in different conditions. That we need to recognise that both marked hypoxia and marked hyperoxia may both cause harm, and in some respects we want to swim between the flags in terms of our delivery of oxygen therapy. The Thoracic Society of Australia and New Zealand, we're currently drafting guidelines for the acute use of oxygen, and they're going to come through to your society for comment and hopefully contribution and buy-in in terms of the final drafting of the guidelines and their dissemination through Australia and New Zealand. So for those of you who the guidelines fall on your table, on your desk, we're very keen to get the involvement of the intensivists in terms of the oxygen guidelines, which we hope to distribute throughout Australia and New Zealand. Thank you.